Right, thanks very much, Colin. So thanks for asking me to come and talk about the heart in RASopathies. I think two of my colleagues have already done an amazing job. So I have included some interesting papers for those, and I'm sure that I can send this presentation to Colin, but I found this a really nice overview of cardiac manifestations in RASopathy. So Emma has already gone through this, so obviously I won't go through what RASopathies are. And again, similarly, Emma has shown that there is kind of a spread of syndromes that are covered here. I really like this slide because I think it shows from maybe a genetic point of view how there is a lot of overlap of the different conditions, and also colour coded, so in terms of how rare they are, but importantly I've put here that from a cardiac point of view they share actually similar cardiac differences. Obviously there are slightly different cardiac manifestations depending on which syndrome you're looking at, but by and large there is a big crossover where there's pulmonary valve problems and hypertrophic cardiomyopathy. So I will concentrate on those two conditions particularly. Very busy this, but again I think it talks to what Emma has shown earlier on, in that depending on your gene mutation and depending on the particular location, that really does dictate the type of differences you see, and that's exactly the same in the heart. But again, you can see running through all of them, problems with the pulmonary valve, and I will show you what that means, and problem with the heart muscle and abnormal heartbeats seem to be a recurring theme throughout. And again, this is just going down to Costello syndrome. Again, you do see other things like holes in the heart and also mitral valve problems, whether that's related to the hypertrophic cardiomyopathy or whether it is mitral valve problems in themselves, I think is something, you know, to be looked at. So again, Emma has kind of gone through, you know, the kind of features and differences we see with the different syndromes. But again, just to highlight here that the cardiac differences seen in the cardiofacial syndrome, again, is the pulmonary valve. Other valves can be affected, holes in the heart, and hypertrophic cardiomyopathy. And again, with Costello syndrome, again, hypertrophic cardiomyopathy, and really any congenital heart defect can be seen, but again, the pulmonary valve seems to be the one that's affected. And again, Noonan syndrome seems again to be more the pulmonary valve, but similarly we can see other syndromes. So with Noonan syndrome, a abnormal pulmonary valve is the most characteristic lesion, but hypertrophic cardiomyopathy is present in up to 30% of patients. But as I say, lots of different types of heart conditions are seen. So I just thought I'd show you some nice pictures of some heart conditions and to explain things. So on the left-hand side here, and if I move around, this is a normal heart. I don't know how much people know, but you've got two collecting chambers and two pumping chambers. And one of the valves leaving the heart, called the aortic valve, can become narrow. So we do see that in the RASopathies.
I don't remember it.
This can be at valve level or can be below the valve. And also we can see narrowing of the main blood vessel leaving the heart. This is called a coarctation. Patients may have high blood pressure or they may have an abnormal heart sound. Also, the connection between the lungs and the aorta, the main blood vessel leaving the heart, can remain open, something we're all born with that usually closes. That's called a PDA, a patent ductus arteriosus. And various holes in the heart can be seen, both between the top chambers and the bottom. And I will give you examples. So because I've said that the cardiac conditions that seem to be shared the most are problems with the pulmonary valve and hypertrophic cardiomyopathy, I'll concentrate on both of those because I can't cover the whole of congenital heart disease in one talk. It's far too big. So, what is pulmonary stenosis? So, pulmonary stenosis is when the valve connecting the right pumping chamber to the lung circulation is either too small, it's narrow, or it's stiff. Symptoms depend on how small the narrowing is, whether you're a child or an adult. Some people, they may only have very mild pulmonary stenosis and really never require treatment, but obviously need to be seen in the heart clinic. But more severe pulmonary stenosis may need a procedure, and we can go through what kind of things we can do. There's lots we can do nowadays. Doesn't mean open heart surgery necessarily. And so, a nice picture. Again, I'll move about and upset the recording. So again, a normal heart, top chamber right and bottom chamber pumping, sends blood to the lung artery. This valve here, think of it as a doorway, allows the blood to go through. But if it's too small or it's too narrow or it's not developed, then there's a hold up of blood getting to the lung circulation. The right pumping chamber becomes muscular because it's had to push the blood harder to get through. And so these are the kind of things we're looking at. As I said, these symptoms can be picked up. So we may hear an abnormal heart sound. For example, your GP might listen to the chest and hear a heart murmur, an abnormal heart sound. In newborns, they may be born with a low oxygen level, so a bluish tinge called cyanosis. They may be tired, there might be poor weight gain, there might be shortness of breath, or they might have an awareness of a fast heartbeat. Sometimes if the hold-up of blood going to the lungs is severe, they may get chest pain, might faint, and sometimes you can see a swollen tummy or legs if the right pumping chamber is struggling. So you can see there's lots of different things there. So it's super important that we have that kind of query in our minds with our patients. So how can we pick up pulmonary stenosis? We can actually identify this before birth, and Emma mentioned about certain things in terms of babies being a thickened fold at the back of the neck, or a big baby, or extra fluid. That can give us pointers. But actually we can scan the baby's heart whilst they're still in the mummy's tummy. And also we can do a heart scan after they're born. And less commonly we can actually measure pressures and pictures inside the heart using dyes and x-rays, which is called catheterization. There are other ways, there are other types of scans we can use. So I thought I'd show you some pictures. So this, believe it or not, is a heart scan of a baby's heart in the mummy's tummy. And this shows that right pumping chamber, the artery going to the lung, and then a very, very tight pulmonary valve here. We put colour on so that we can see what the flow of blood is. And when you get lots and lots of mixed colours here, that means the blood is under high, if you like, pressure or high flow, telling us that there is a narrowing. Okay. Sometimes the valve can leak. And we can treat babies still in mummies' tummies with balloons if the heart is really struggling, so there's specialist units to do that. So in an adult, the heart's obviously a bit bigger, and again this is the pumping chamber, this is the pulmonary valve, and as you can see here, then there's narrowing and a hold-up of blood. We can also use more fancy detailed scans, so we can use MRI scans and CTs. We can do MRI scans even in babies that are still in the mummy's womb. But this is an adult patient here. Their pulmonary valve was narrowed, and so the blood vessel after that going to the lungs is bigger than it should be. Again, here's another view. This area here, which looks a bit brighter, is the hold-up of blood going through the valve going to the lungs. And again, you can see here another feature of a narrow pulmonary valve. So we're very lucky in cardiology to be able to directly look at the heart really from very early on. So those top left pictures of a fetal echo is taken at about 20 weeks, so halfway through the pregnancy, even before we can take these pictures. And we can pick up abnormal heartbeats this way as well with an echo, because we can actually see how the heart is moving and how fast. So how might we treat it? Okay, so in some cases, as I said, it's mild, it just needs monitoring. Okay, but there are other ways we can open a valve or fix a valve that's not working well. One way we can do that is using a balloon, and we can actually do this in pretty young children, so I'll just let that play again. So if I just get you to concentrate on this bit here, this is the narrow pulmonary valve. I'll play it again. And this is one of our patients, and you can see the mixed colour blood, okay? We can measure how narrow that is. And so if you have a look at this picture here, I'm just going to show you that we can pass a balloon and we can open the balloon and then relieve that narrowing, okay? So this is one of our patients. So we've got this piece of tubing up through the leg, or we can go through the arm, or we can go through the neck. And we can take a picture of the circulation going through that valve. Okay. And we can see here that the valve is narrow. And then, in the same procedure, we can inflate a balloon, and you can see narrowing here, and then it's not narrow, so we've stretched the balloon open, and that works really very well. It's a very common procedure in childhood. We do it less often in adulthood, but we can do it in adulthood, and you can do it repeated times. If we can't do anything minimally invasive, so keyhole, then obviously we can consider valve surgery, okay? Using an artificial valve or a valve from a donor. What kind of valve depends on lots of things. So here's that position of the pulmonary valve, and these tend to be the type of valves we use. They're tissue valves, so you don't need blood thinning medication. They last anywhere between 10 to 20 years, depending. So they do need something doing usually. But nowadays, we can put valves in up through the top of the leg without open heart surgery. So a bit like the balloon, we have the valve which is crimped down on the balloon. We put it in the right position, and then we leave the valve there. Okay. And they last again, anything between 8 to 15 years. And we can put, a bit like a Russian doll, we can put another valve in that valve if that becomes leaky or narrow. Can do that probably up to 3 times depending on the patient. And there's different size valves. So it's important for patients to know, though, that if we do deal with a narrow valve, or indeed a leaky pulmonary valve, that can come back again. And so it's not a curative condition. We might need to do repeated procedures, and that's important for people to understand. But also I think it's incredibly empowering knowing that there's things that can be done. So I'll move on to hypertrophic cardiomyopathy next, because that's probably the next most common cardiac condition we see across the syndromes of RASopathy, particularly in Costello syndrome. And there's some really excellent guidelines. There is a lot of information about hypertrophic cardiomyopathy, the most recent of which is 2023, which covered all type of heart muscle diseases. So what is hypertrophic cardiomyopathy? This is an umbrella term, it's not one single thing. A cardiomyopathy is a problem with the heart muscle. Okay. The heart muscle itself, in how it's being developed and how it works, is abnormal. And it's important to make sure there isn't any other cause of the heart muscle becoming abnormal in its structure and function, because other things can impact your heart muscle. And so obviously in the heart clinic, this is something that we do. So in adults, we start to think if this could be hypertrophic cardiomyopathy if the left pumping chamber wall is thicker than 15 millimetres. It may be slightly less, but then there might be other features such as a family history or genetic findings in our patients, or ECG abnormalities. In children, it's a variation from what is normal, a bit like Peter said with regards to height and weight. It's 2 deviations thicker than what we would expect for that child being male, female, and their body size. So as I said, hypertrophic cardiomyopathy is an umbrella term. There are lots of different causes for it. The vast majority gene mutations not related to our patients, related to the building blocks of heart muscle themselves. 25 to 30% are actually unknown, but 5 to 10% cover other genetic causes of which our patients fit in there. So you can see there's lots of patients with hypertrophic cardiomyopathy that won't have a RASopathy. They may have another genetic condition. I think this is, for me, probably the most important slide, is that for our patients, and a bit like the slide that Peter showed, actually looking after our patient requires a lot of different specialities and input for people to be optimally cared for and advised. And certainly I'm a great advocate for joint clinics, so that you're not coming to 5, 6, 7 clinics in one or several hospitals. So when we have one of our patients with potentially hypertrophic cardiomyopathy, how do we approach this? Obviously, we need to take personal and family history, examination, we do a heart ECG, we image, and we do some first-line laboratory tests. Genetics is incredibly important as part of this. And as I say, there are lots of different types of hypertrophic cardiomyopathy, but if we look particularly at our group of differences with the RASopathies, there are some things that even to a doctor who's not used to looking after our patients, that it might point a bit more to one of our patients. And we do pick up Noonan syndrome and related disorders in adulthood very frequently. They often might just be slightly shorter than normal, and actually not have a lot of the classic features, so it's always just keeping that mind open. So particularly if the right pumping chamber is narrowed or thick, it should make you think, actually, could this be one of the RASopathies? But with our patients and with hypertrophic cardiomyopathy, that increased wall thickness can be found at any location, okay? So there's a high variability in how our patients will be affected, but also it's not only about wall thickness, it's about the function of the heart muscle, it's about relaxation, it's about the mitral valve, so this valve here that is related to the main pumping chamber, and the area underneath the aortic valve leaving the heart, which is called the LVOT, and it's about scar. So you can see this very muscular pumping chamber here, and when we do certain tests such as MR scan, we can actually look at scar. But the MRI scan will also show us different abnormalities that might make us think that somebody has got hypertrophic cardiomyopathy. So these so-called crypt in the heart muscle, the mitral valve might have a big long leaflet, and also abnormal trabeculae, which is part of heart muscle. So you really have to have a very, very low index of suspicion to make this diagnosis. So I thought I'd show some real-life pictures, and Helena has given me permission to use these. So this is Helena's heart. Okay. So if we look in the short axis, we call it, we can see how muscular this is here. And also these muscle, if you like, lumps are what we call fragmented. Okay, so I'll play that again. Okay, so you can just see, it's like a donut, but it's an extra thick donut. Okay. This is Helena's heart. This is the pumping chamber here. This is the valve leaving the heart. And this is important because if I play it again, you can see this leaflet of the mitral valve is very long. Can you see? And how it's kissing the heart muscle. Okay, so this next one here, I've not gone through this in so much detail with you before, Kath. And again, this long leaflet, I'll get it to play, and you can see that when it moves, it hits this wall here between the two chambers. And that is pretty diagnostic of hypertrophic cardiomyopathy. So it's called systolic anterior motion of the anterior mitral valve leaflet. We always have to have very long words. And this is just the flow of blood. And remember, I said anything that's multicoloured is going at high speed. And you can see how multicoloured that is. So the hold-up of blood leaving the heart is increased because that leaflet is getting in the way and the muscle's getting in the way. And we measure how held up it is by, these are called Dopplers, okay? And this typical dagger shape is showing me how much the blood is being held up, leaving Helena's heart. But Helena's heart works well. Okay. And remember I said hypertrophic cardiomyopathy can affect the mitral valve. Well, then you can get a bit of a leak of the mitral valve, which again, Helena has had for very many years, but her heart is coping with it well. So thanks, Helena. The most important thing for hypertrophic cardiomyopathy is to identify how much that blood is held up leaving the heart. This is called left ventricular outflow tract obstruction, holds up of blood leaving the heart, okay? And it's important to do it not only when someone's laying down, but we can actually get them to clench their hands or move their legs or when standing, because obviously if you lay down and resting, the heart is resting, and we want to know how much the blood is held up when somebody is actually exerting. The important number is 50. If it's greater than 50, so that means that the heart is really having to work pretty hard at pumping blood out, then we go and look at other recommendations of how to look after it, but also symptoms are important. If they don't have symptoms, then we repeat the heart scan. But if they do, there is other ways of us to see how much the blood is being held up. And this is a treatment. So if there's no symptoms, you can treat them with medication, so either beta blockers or verapamil. And if there's symptoms, we can go down different medications, okay? And I've starred this medication here, which is called mavacamten. So this is a new kid on the block. So I thought it was important to mention it. So mavacamten inhibits your heart muscle units, okay? So basically how a heart muscle works is they have these filaments, they have these little bridges, and they have a thicker filament, and they're like ratchets. They pull themselves along, and that causes the heart to contract. So that's normal. With hypertrophic cardiomyopathy, the heart muscle is extra contractile, okay, so it's working hard. It doesn't relax very well, the heart is stiff. And also, the way the heart uses its energy source is abnormal, so important what Peter was saying in terms of energy utilisation. What mavacamten does is help stop the hypercontraction, improves the relaxation, and improves your energy usage. So it'd be interesting to see how this medication changes things in the future. But as cardiologists, we like to do things as well as prescribe things. So if the hold-up of blood leaving the heart is severe and people are still symptomatic, so still have shortness of breath, chest pain, passing out, those kind of things, then we can do other things other than medication. Some of my surgical colleagues can go in and chop a bit of muscle away to ease that flow. That is called a septal myomectomy. Clearly that requires open heart surgery. So all of the other risks associated with surgery with our patients is associated with that. But also we can do essentially this by injecting some alcohol into the bloodstream to this area of the heart, going up through the top of the leg again, and that is called alcohol septal ablation. Again, a general anaesthetic, but you're usually only in hospital overnight. We can also use different types of pacemakers and defibrillators if we can't increase medication or do any kind of procedure to improve that hold-up of blood leaving the heart. Everybody is individual. And so what kind of follow-up should our patients with these heart differences have? So they should all, at a minimum, have clinical evaluation, including an ECG, a heart scan every 12 to 24 months if people are stable. More frequent if needed. If symptoms change, they need to be seen and those things repeated. Every 2 years we might do an ECG over a 2-day period. And that's just to make sure that they're not getting any abnormal heart rhythms, but often patients know if they're getting that. MRI scan, giving you those detailed pictures, can be considered every 5 years. But if you're getting good heart scan pictures, there's no reason to do that. And we can get patients to do exercise every 2 to 3 years if we think that the hold up of blood is a bit more than the heart scan is showing. And if able, proper heart-lung exercise testing. That can be quite difficult in our patients who have mobility or skeletal problems for them to do that. And again, these are levels of evidence, okay? When it's green, it's good. When you're starting to get to yellow and red, there's not a lot of evidence. It's the top and bottom of it. So the top two, definitely. What about reproduction? So babies, people don't talk about that in our patients group very much. I know Peter was talking about puberty, but I don't know whether he went on to talk about, actually having children. Certainly in some of our patients, certainly Noonan's patients, they can have children, and it's not unusual for us, and I think Emma said, to actually pick up parents with a condition when we actually see their children. So that definitely happens in the heart clinic. So all women with heart problems need to have a proper pre-pregnancy risk assessment. So not at the time that they become pregnant, beforehand, okay? And counselling about what pregnancy might mean for them, might mean for the baby, might mean for the future. It's important for us to talk about contraception, and actually there is no restriction really in our patients in terms of the form of contraception. And it's also important for us to counsel mum but also dad about the risk of disease transmission in future children, and that's where colleagues like Emma are really helpful in counselling. And medication generally, beta blockers are safe in pregnancy. Whether or not we should have our patients on blood thinning medication, I think it's a case-by-case basis. I'm a great advocate of exercise, as Kath knows, and so all of our patients should undergo exercise within their own abilities. Patients who have hypertrophic cardiomyopathy should avoid competitive sports, however. And again, a heart talk cannot be complete without talking about diet, alcohol and weight. If you have got a significant valve problem in the heart, smaller, more frequent meals are important because heavy meals might provoke their symptoms. And no one should ever smoke ever, and that includes vapes. Okay. Nobody talks about sex. It's important in our patients, in those, where it is appropriate. So it is important when it's appropriate for a patient to actually talk about that and how that impacts the heart, or how the heart might impact that. And it's important people are fully knowledgeable about their medication, vaccinations, and we also have helpful information regarding driving and occupation, holiday and travel and all of those things, which is a bit more beyond, but as most people know, trying to get holiday insurance for patients with any lifelong condition is nigh on impossible unless you need to remortgage your house. There are some heart more appropriate insurance companies. On the Somerville Heart Foundation website, which is for congenital heart patients, but it still has good information, and also the British Heart Foundation, they do have some helpful insurance information. And so what is the future? So there is now researchers looking at MEK inhibitors, and one in particular called trametinib, and whether this can reverse hypertrophic cardiomyopathy and valvular obstruction, particularly in patients with RIP1-associated Noonan syndrome. And so I think this is actually an area to watch and to follow closely. Certainly the research does show that there does appear to be some regression of the heart muscle hypertrophy and possibly a slowdown of valve obstruction, but I think it's still early days in terms of the MEK inhibitors. And that's the end of my talk. So if anyone has got any questions, I'm more than happy to answer them.